Assalamu alaikum. The short clinical day. First scenario, Mr. John Smith. He is 55 years old. He has pallor. Please examine his abdomen. Yeah. Now you can start, Dr. Say. Here you go.
Yeah. Good evening. I'll enter the room. Um, I'll say good morning to the examiner. I'll wash my hand to the hand rub. Then I'll go to Mr. Smith. I'll introduce myself. Hello, I'm Dr. Sen. I'm doctor today. I've been asked to examine your tummy. Is that okay?
Hello, doctor. No problem. Go
Do
on.
you have any pain in your tummy?
No.
In the process, if I do any discomfort, please do let me know.
Okay, I will.
Okay. So I'll just first inspect from the foot end for any obvious deformity or any features are there. Then I'll come to the to Mr. Smith. I'll ask him to show his extend his hand.
Okay.
Uh, I'll
What?
see for I'll see for any clubbing, any icterus, any Euless discoloration. I'll look for any tremor in the hands,
No clubbing.
and then I will ask him to cock his wrist up to look for any flapping tremor.
No hernia.
Uh, no flapping tremor. Then
No
I'll
clubbing tremor.
yes, I'll see the pulse.
It's regular, 70 beat per minute.
Okay. In the palm, is there any hyperpigmentation of the palmar creases?
No.
Okay, then after seeing the pulse, I'll run down my hands over the both the hands to look for any fistula, any scar mark, any tattoos.
No.
Then I'll go to the neck, look for the JBP. I'll go to the uh, first oral cavity to look for any gingival hyperplasia, look for any dentition, oral ulcers, any pallor in the tongue, any dehydration in the tongue.
There is pallor.
Okay. Uh, then I look at the eye, look for any pallor and any icterus,
Pallor, no icterus.
any facial deformity, any malar prominences, any malar flush,
No.
temporal hollowing, any temporal balding,
No.
no facial.
No.
Okay, then I'll go to the abdomen. I'll do the superficial palpation on the all nine quadrants of the abdomen, superficial palpation. Then I'll go to the deep palpation in all nine quadrants. If any tenderness in organomegaly is found,
There is no tenderness.
then I'll start with the palpation of the liver, with starting from the right inguinal region, going up laterally with the inspiration. Look for the any hepatomegaly,
No hepatomegaly, palpable.
no palpable hepatomegaly. Then I will just percuss over the ribs to understand the upper level of liver dullness.
It's normal liver span.
Okay, then I will look for the spleen, starting again from the right hypochondriac area, going obliquely towards the left costal margin,
Spleen is enlarging, palpable at the level of the
umbilicus. Okay, okay. If I palpate the spleen, then I will just percuss over it, and I'll auscultate over for any bruit or any tenderness, and look for the splenic notch, look for the surface. Any tenderness is there.
There's no tenderness, not pallor.
Okay, and then I will see for the kidney for any palatable mass there or not.
Not palatable.
Okay, I'll auscultate. I will percuss for any shifting dullness in the abdomen.
There is no. What you, Prakash? Sorry?
I'll for the shifting dullness for any free fluid inside the abdomen.
No shifting dullness, no ascites.
Okay, okay. Thank you. And I will auscultate in the abdomen for renal bruit and for peristaltic sounds.
Normal peristaltic sound.
1 minute
Okay, then
left.
I will make him sit, look for any lymphadenopathy in the neck.
No bulb of lymphadenopathy in the neck.
I will ask for any back pain, is there or not? Palpate the back for any sacral edema. Any sacral edema. And I will go to the foot end to look for any pedal edema. And we'll ask him whether he has any pain in the leg or not. Hello, can you hear me?
Yeah, we can hear you. I think the problem from Dr. Ahmed's side.
Okay, okay.
Waiting for him.
Yes.
Anything else you want to offer?
I'll offer to look for the hernian orifices, and I'll end my examination with digital rectal examinations.
Perfect. Perfect. Amazing. So we will wait for Dr. Ahmed to start the questions. Time is up.
Okay. Present your case, please.
Okay. I have examined this middle-aged gentleman, Mr. John Smith. Uh, on a general physical finding, I have found to have pallor, and on palpation of the abdomen, I have found a moderate to severe splenomegaly, which is non-tender, uh, and splenic mass is palpable, and along with that, uh, so that is the only physical finding. So he's having anemia with splenomegaly, moderate to massive splenomegaly.
What's your differential diagnosis?
Okay, my first differential diagnosis looking at his age and this physical finding would be any myeloproliferative disorders. I would like to confirm these things with proper history. Second differential diagnosis with will be myeloproliferative disorders like chronic myeloid leukemia or and myelofibrosis. And my second differential diagnosis will be any chronic infections like chronic malaria or chronic kala-jor that we see quite endemic in our subcontinent. And third differential diagnosis will be mm, third differential diagnosis will be any mm, uh, any hemolytic anemias like hereditary spherocytosis.
Good for differential diagnosis. But regarding leukemia and lymphoma, did you examine lymph nodes outside
Yes,
the cervical lymph nodes?
no, I have examined the cervical lymph node. That is not found, so I would have offered the um, axillary lymph node. I have not examined the axillary lymph nodes and inguinal lymph node.
The patient has a scar in the right axilla. This was removed lymphadenectomy.
Oh, scarlet axilla. Okay, I have not examined the axilla.
What's your workup?
If there is an lymphadenopathy, previous history of lymphadenopathy, I would like to confirm the diagnosis with blood tests and the complete blood count. Along with that, I will do the bone marrow examinations, and also I'll do the cytogenetic study and the FIS in the peripheral blood smear. Uh, and also I would like to check the reticulocyte count, LDH, and serum haptoglobulin, and uh, bone marrow biopsy.
Very good. How to treat?
Um, if the diagnosis is any lymphoproliferative or myeloproliferative disorder, then in that case, I need to do a proper patient education and the counseling, and we need to form a multidisciplinary team approach along with the hematologist and uh, along with first the hematologist and specific and the dedicated nurse with uh, and the dietitian, and we need to if it is a any lymphoproliferative disorders, then we might need, or any myeloproliferative disorders, then we might need to give chemotherapy.
Thank you. Very good.
Yeah, time is up. Pause for a minute for the examiner and 6-minute examination. Any other question, Dr. Ahmed, you want to add?
He done very good,
Okay,
systematic,
you can comment. Yes.
but he missed the sign of liver cell failure for spider nevi to look for gynecomastia. And he missed in the examination also to examine other lymph node sites like axilla or inguinal. Otherwise, he done very good.
Okay,
Okay,
so
yes,
yeah, the
yes.
skills, based on the skills, how you can score the physical examination skill first.
Examination borderline because he missed two things: manifestation of liver cell failure and also the other sides of lymph node lymphadenopathy. So borderline in the physical examination, and the physical finding also borderline. Clinical judgment satisfactory, patient welfare satisfactory.
The
Thank you
differential.
very much.
Differential satisfactory.
Okay, perfect. So from your side, can you give us the complete features and picture of this patient along with the differential? Just for revision, what he missed, then we can, I will comment. So it's a case of splenomegaly with previous lymph node excision, right?
Yes.
Okay. Patient present with pallor. Other finding, any sign of chronic liver disease?
No.
Okay. By the way, while you have some internet disconnection, he mentioned the digital rectal examination.
Yes, I hear that.
You heard? Okay. And the other lymph node, did he mention other lymph node as an offer to examine?
No, he examined no cervical lymph nodes.
Yes. Any case or any abdominal case, whenever you have lymph nodes, or sorry, spleen, as palpable spleen, you can offer the examination of the lymph nodes, the inguinal group. Okay, it's not only the axillary. Axillary, yeah, it's easy to do without offering, but the inguinal usually embarrassing, so you cannot do it unless you offer it. If the examiner accept to do, you can go and proceed. Otherwise, just offer it. And don't forget to look for the signs of chronic liver disease. This is regarding the possibility of the diagnosis or the finding. The diagnosis based on this finding, it's features of lymphadenopathy along with splenomegaly. Could be liver as palpable. Dr. Hussein, is it possible to have hepatomegaly with these patients?
Yes, if it is a myeloproliferative disorder, CML or
Perfect.
myelofibrosis, then
Yeah.
liver is usually not palpable, but yes, there could have been hepatomegaly as well, and liver would have been palpable. Suppose if it is a CLD, then the liver should have been palpable, or liver could have been palpable.
Yeah. So there is possibility to have palpable liver. Okay. The next question: what are the possibility to have cirrhotic liver? Is there any possible cirrhosis in those patients?
Yes, Shari, can you please frame your questions again? I could not hear you.
Again, okay. If we mention the chronic liver disease as a finding or signs in those patients, myelo or lymphoproliferative, is it possible to have shrunken liver or cirrhotic liver with a finding of signs of chronic liver disease? Is it common?
Yes, yes. The only thing, the size of the spleen is quite big, so that is why I didn't offer the it is almost reached to the level of umbilicus. So it was indeed quite massive splenomegaly. In cirrhosis of liver, there is no peripheral stigmata of chronic liver disease like leukonychia, and uh, I have asked for whether he has any parotid swelling or malar flush or any jaundice is there or not, or any temporal wasting is there or not. So there is no gynecomastia. I could not check. I forgot, but there is. I in the in chronic liver disease, I would have got an evidence of spider nevi or gynecomastia, and there would have been a possibility of having free fluid inside the abdomen.
Okay. Again, I will repeat my question because you may didn't understand it.
Oh,
Um,
okay, sure.
I'm asking, what a possibility to have cirrhotic liver with those patients as a chronic myeloproliferative or lymphoproliferative? Is there any possibility to have shrunken liver
Oh, okay.
or cirrhotic
Uh,
liver? I mean, the sequel of cirrhotic liver and chronic liver disease. Is it
uh,
possible? You get my
I'm not.
question?
I'm not very sure.
Okay, Dr. Ahmed.
Yes, when the case bilharzal fibrosis, for example, complicated by portal hypertension,
No, no, not bilharziasis. Our case today,
it,
myeloproliferative or lymphoproliferative. Is it possible to be as cirrhotic complication, liver cirrhosis?
I didn't have clear correlation with both myeloproliferative and cirrhotic liver.
Okay, whenever we have the features of chronic liver disease, what could be the reason of chronic liver or cirrhotic liver disease? Are we mentioning the lymphoproliferative and the myeloproliferative, one of the causes?
Yes,
So is there any possibility? Yes, there is possibility. In particular, if you have, for example, liver mass, right? And it could be also complicated with hepatocellular carcinoma, and it can also lead to the cirrhosis, right? So any infiltrative disease, we can say one of them, the lymphoproliferative or myeloproliferative disorder. However, it's not common, but it's still one of the possibility to have it, right? As a cirrhotic liver disease sequelae. Our case today, no other manifestation of chronic liver disease, right? But there is splenomegaly with lymphadenopathy or previous lymph node excision. So we don't have the features of chronic liver disease. The other differential for such age, let's repeat them, Dr. Ahmed. Our case today about lymphoma, right? You want to say lymphoma?
yes.
Okay, so on the top of my differential will be the lymphoma. And he might go with you what types of lymphoma you know. So you can say the Hodgkin or non-Hodgkin. And what's common in this age, Dr. Ahmed?
Non-Hodgkin's lymphoma.
The what?
Non-Hodgkin's lymphoma is common at 55 years of age.
Non-Hodgkin. I
Yes,
think
Hodgkin's lymphoma is more common
Hodgkin.
in
Yeah,
younger
the
age.
Hodgkin, not the yeah, the Hodgkin.
Okay.
What I remember, the non-Hodgkin comes in the elderly or the youngest. It has a bimodal appearance, right? Anyone also
Okay.
can correct this if not correct. But what I remember, the non-Hodgkin appears as a bimodal age distribution, early age and or young age and the elderly. I think 60 and above. Anyway, we can.
Uh,
Sorry.
I feel it is the classic Hodgkin's lymphoma which has bimodal uh,
So the
age of
opposite, you mean?
distribution.
The
Yes, yes,
Hodgkin?
I feel
Okay.
so. Yes, yes.
Okay. Someone can confirm it while discussing. The other differential, apart from lymphoma, what you mentioned, Dr. Sen.
Uh, it could have been chronic lymphocytic leukemia, CLL, at this age,
So still
which
you are talking about lymphoproliferative.
Yes, yes.
Okay,
And the other prolif things, because here there is an excision of the lymph node, so that is why lymphoproliferative disorder came to the diagnosis.
okay.
Otherwise, CML and the chronic myeloid leukemia and the
Yeah, this is
myelofibrosis.
myeloproliferative, yes. Myelofibrosis, yes.
Yes,
Especially if you have a huge spleen, right?
yes.
Okay, and you mentioned the malaria, one of the causes. So you can say infectious causes.
Infectious causes.
Yeah, one of them malaria, and as you said, I would like to take history about travel history in particular. Okay. What
Yes.
else you mentioned?
Uh,
Hemolytic anemias, right?
Chronic hemolytic anemia with hereditary spherocytosis. But
Hereditary
only thing that the
spherocytosis.
age is quite against it. So usually the patients are younger and they usually
Perfect.
have
Yes.
phases of hemolytic phases.
Perfect. What else you can have or you can get from the history? Supposed to say
Multiple blood transfusion history you should have got.
multiple transfusion and family history.
Family history.
And what the mode of inheritance of hereditary spherocytosis?
Autosomal recessive, if I'm not
Non-autosomal dominant.
wrong. Sorry.
Okay, let's go to the cause as chronic hemolytic anemia, the sickle cell. Can you mention the sickle cell in this patient?
No,
Yeah, what
usually no,
against?
because in sickle cell disease at this age the spleen would have been atrophied.
Perfect. Yeah, autosplenectomy, so you might not feel the spleen,
Hmm.
right?
Hmm.
Or if you couldn't feel the spleen in other chronic hemolytic anemia, what could be the reason? Supposed to be
Uh,
splenomegaly, right? And the
mhm.
thalassemia, and also our case, our other differential hereditary spherocytosis. But if you couldn't feel the spleen, you will look for what?
Scar, splenectomy scar. I would look for the
Perfect.
splenectomy scar.
Yes, splenectomy scar. And what other scars you might have in those patients?
Midline laparotomy scar as well,
Okay, and
and the gallbladder cholecystectomy
perfect.
scar.
Perfect, yes. Cholecystectomy scar. Yeah, perfect. As well as for the pallor. So most of those patients will have chronic anemia with the recurrent history of transfusion, right? As you
Hmm.
mentioned. The management and the investigation supposed to be fixed all over, but what are the specific investigation for lymphoma?
Bone marrow examination.
This is as invasive. Again, start with the blood first. What is the blood test you have to do or you want to do?
So we'll do a complete blood count with peripheral smear examinations.
Perfect.
First of all,
Uh,
we would like to do the
Very
red blood cell.
important.
Hemolytic screen may be associated with autoimmune hemolytic anemia, abdomen.
Okay, hemolytic anemia as a complication. So you will do LDH, all the hemolytic or hemolysis workup, LDH and bilirubin total and direct.
and
Uh,
uh,
bi- yeah, continue. Yes, what?
and the serology for Epstein-Barr virus.
Okay, let's talk about category by category. If Epstein-Barr virus, if you want to rule out infectious, I'm talking about lymphoma itself, how to confirm the diagnosis from blood point of
We
view.
can we can do a
And
flow cytometric study.
yeah, this is what I want you to say. Flow cytometry as a specific investigation for lymphoma. You have to mention it. Okay.
Yes.
And the other investigation we mentioned, CBC for anemia, the inflammatory markers, as well as the hemolytic or the hemolysis workup, as Dr. Ahmed mentioned, right? And then the invasive will be very diagnostic one,
Lymph node biopsy.
lymph node, or sometimes also it might be as bone marrow if you suspect myeloproliferative. Okay, so we are talking about both categories together. We are done with the lymph node or lymphoma or lymphoproliferative or myeloproliferative. What about the infectious, as Dr. Ahmed mentioned? All virology or viral serology, including Epstein-Barr virus, or if you want to do malaria. So the specific test for malaria, Dr. Sen.
Sorry, can you
What
please
is
again?
the specific test for malaria?
We will do peripheral smear examinations both thick smear and the thin smear, and rapid
Perfect.
malaria
Yeah,
antigen test.
perfect. Yeah, this is what I want you to say. So, sorry, blood film, thick and thin. Okay, looking for the type and the species. And the hemolysis again work up because it might be associated with hemolysis. And this is for infectious or the viral if you want to mention. HIV also if you suspect history. After the history of taking, of course, you have to mention it. These... Okay, what other category you can add to the splenomegaly? Apart from infectious, lymphoproliferative, myeloproliferative, hemolytic anemia.
Infiltrative diseases,
Perfect.
Yes,
And in the
Gaucher's
term
disease.
of...
amyloidosis,
Perfect. And
maybe
Gaucher's disease. Gaucher's.
alpha 1 antitrypsin deficiency.
Gaucher as storage disease,
Yeah.
right?
Mm.
Or metabolic cause. No, I'm talking about other infiltrative. So whenever you mention the infiltrative as the what you mentioned already, the amyloidosis, you can remember also the hemochromatosis, right?
Yes.
Yes, yes.
Both of them are infiltrative disease. Okay, we are done, I think, with all causes, how to investigate, how to... And how to manage, you have to say according to the cause. So I will manage according to the cause. If they want to specify a cause, for example, the lymphoma, how to manage the lymphoma, as Dr. Sen mentioned, after staging, don't forget the staging in both patients, the myelo or lymphoproliferative.
The stage here is for above and below and spleen involvement.
Perfect, yes.
POs,
What this criteria called?
uh,
And Arbor taking criteria?
an arbor or something like that.
Yeah, I'm not sure about the name, but there, it's criteria whenever you have... it's like staging. So above the diaphragm, as you said,
Arbor. It's
blood
an
the
arbor.
side. Again, sorry?
It's an arbor's
Arbor.
criteria. An
Perfect,
arbor.
okay. Perfect. So you can consider it one of the investigation tools. Why? Because the staging will give you also the prognostic factor. Is it treatable or just palliative, right?
Yes.
In particular, if you have a lot of groups above and below the diaphragm. And what can make the prognosis worse?
Lymphocytic.
No, I'm not talking about histopathology. I'm talking about general manifestation. It can worse the prognosis in any lymphoma.
B symptom.
Older age?
Perfect, yeah, B symptom. So if there is B symptom, so it make the prognosis worse. Okay, so again, the management depends on the type or the cause. And don't forget to mention the multidisciplinary team approach to manage your patient. Okay, any question for
Yes,
the previous case? Dr. Hussein and Dr. Ahmed?
No, thank you.
yes.
Covered.
That's indeed a very good case, Dr. Ahmed. Thank you very much for your inputs.
Yeah. By the way, Dr. Hussein and Dr. Ahmed, sometimes I can swear one doctor at one day of my session, she had a case, she just presented or had it 2 days before the exam. So you will be lucky if your exam soon and you have this patient and you will have this discussion. That's why we are encouraging to attempt with us and to have a practice.
Thank you.
Okay, most welcome, Dr. Sen and Dr. Ahmed.
Thank you.
Sorry,
Yeah,
Dr.
so
Bassem, it's just to clarify, did
Yes.
Dr. Hussein ask the patient to lie flat or not? Because I didn't hear that.
no, yes, good point. This is Dr. Omar, right?
Yeah.
Okay, so whenever you are examining the patient, Dr. Sen, uh,
Mm-hmm.
yeah, the abdomen, before starting examining the abdomen, be sure that you put the patient at flat position. By the way, most of the beds in the exam, they are telling to you it's like this. It's fixed, so you cannot play with the parameter or you cannot change the bed position. But if you have that bed, the couch which you can be sit to be flat, you have to put the patient flat. I remember
Yes.
in my attempt, I couldn't change the bed. So they told me proceed with like this, and the bed already flat. But sometimes they can put, to be tricky more, they can put the patient in semi-sitting. And if you continue examination without putting the patient flat, they will minus you. And don't forget to say that I want to examine the GVP. Okay, you have to examine the GVP or you to check for it, and you can check it also in the semi-sitting position, not in flat position. This is the opposite. Okay.
Yes.
Yeah.
What's the two stations you will need to make the bed flat? This is a question for Dr. Singh.
Okay, Dr. Sen.
Abdominal station patients needs to be flat. Somebody with a lower limb examination, the patient needs to be flat.
It's the headache station because you need to do Kernig's and Brodzinski. This is the two, the important two station you need to remember to put the bed flat if it's flat. And as Dr. Bassem said, in some it depends on the facility in the center. Sometimes they don't have flattable beds, but if they do have adjustable beds, the patient can't lie for 2 hours flat. Between every other doctor, he won't sit in a 45, especially if he had a ascites or something. So it's not only to trick, but it's because the patient himself needs to rest his back in a 45-degree. So for the abdominal examination, do the front examination, ask the patient, sit the patient up to examine the lymph nodes, rest the bed flat, to remind yourself to rest the bed flat. After the lymph node examination, after the general examination, lower the bed down if it's lowerable, and then put the patient flat after asking him, are you able to lie flat? Sometimes if this is your last station and the patient is lying for like 2 hours, the examiner might say, no, the patient is not comfortable, carry on. Did you get my point?
Yes, okay.
Okay, there is question why headache supposed to examine the headache for in a flat position.
Is it for me or for Dr. Sen? Sorry.
It's okay, Dr. Sen, if he can answer.
Yeah.
Why
Headache?
in headache position, or sorry, in headache situation or scenarios, you have to put the bed flat?
In headache, so we can suppose somebody in the LCC comes with headache, we can do examination in sitting position as well. Like if we need to do a cranial nerve examination, we can check the visual acuity, visual
No, the
field.
cranial nerves in sitting position, it's okay.
Yes,
In particular, the headache. Why in headache scenarios, the bed's supposed to be flat? It's not
I
direct link, but indirect link. So it's not related to the headache itself, but related to something can cause the headache.
See if
Or
meningeal irritation, meningismus.
perfect, yes. So this is the reason
Kernig's and
what is
Brodzinski.
for the Babinski and also for the neck stiffness,
Yeah,
right?
for
okay?
Kiernan and Brodzinski, you need to make the bed flat to assess for the neck stiffness, and then for the Kiernick sign, when you raise his knees,
Perfect.
and then ask him to straight it. So the bed needs to be flat.
Yeah,
If you are doing it, you need to make sure that the bed is flat.
yeah.
You
So
can't do
both
it
for
in both.
meningitis. Yeah,
Yeah, if you want to rule out meningitis, if it's an acute headache and it's subarachnoid hemorrhage, or you have to do the meningitis, you have to test for signs of meningism in that station.
perfect. So it's not, as I said, not for the headache per se. It's something related to the headache, which is very serious to find out in those cases. In brackets, the meningitis or any meningism like in subarachnoid hemorrhage. So be sure that you put the patient in a flat position. Good to mention. Thank you, Dr. Omar. So again, because there is a question, what two position or two scenarios to have to put the bed flat? either if you suspect meningitis or signs of meningism, like in subarachnoid hemorrhage, or the second scenario, the abdominal examination scenario. When you start to examine the abdomen, not in every step, only when you start examining the abdomen, okay?
Okay, okay.
Yeah.
Thank you.
Is it clear for a doctor who asked this question? I will read the question quickly and the comment in the chat box before moving forward to the next scenario. Why headache station patient should be flat? We mentioned it already. Doctor mentioned 2 stations, so I mention it again. The headache for meningitis or related to meningitis or related to subarachnoid hemorrhage, if you suspect any of them. Thank you, Dr. Samira, for sharing this photo. I can share, and you can share it to the WhatsApp group to be more helpful for others. This is the characteristic features, either the origin like B cells or T cells, Hodgkin B cells, T or B for non-Hodgkin. The cell or histopathology finding, Grid Sternberg cells, as we know, OLI appearance. It's not appeared in non-Hodgkin lymphoma. The age distribution by model, thank you. It's here the information I mentioned. It was about the Hodgkin, not the non-Hodgkin. So either very young or more than 55. And while the non-Hodgkin can occur at any age and more common in older adults. Lymph node involvement, localized and contiguous spread, typically cervical node in the Hodgkin type. However, the non-Hodgkin multiple peripheral nodes or non-contiguous spread. So it can appear everywhere in any group. Extranodal involvement, very rare with the Hodgkin, and it's very common with the non-Hodgkin to appear in the GI tract, skin, CNS, etc. The symptoms: painless lymphadenopathy. B symptoms: fever, night sweats, weight loss with Hodgkin. And the non-Hodgkin, similar symptoms, but B symptoms less common in low-grade types. The mediastinal mass common with the Hodgkin, especially in young adults. Nodular sclerosis type, and it's not or less common in non-Hodgkin. The prognosis generally excellent, especially in early stage. In the Hodgkin, while in non-Hodgkin, it's variable, depends on the grade, the type, indolent versus aggressive. By the way, regarding the prognosis, even sometimes in the communication scenario, if you have a Hodgkin counseling, Hodgkin lymphoma, it's not a bad or breaking bad news. You can say it as just concerning news, or you don't have what I would say not as bad news. Why? Because the curative rate is high, so it's not as bad as the non-Hodgkin. Okay, there is possibility to have chemotherapy, there is possibility to have medication. However, the cure rate is high, so it's not as breaking bad news. This is the only type of cancer you can say in concerning, not as bad news. Okay, the associated infection, Epstein-Barr virus, can appear with 40 to 50% in Hodgkin, sometimes linked to HIV, Epstein-Barr virus, human T-cell lymphoma, and Helicobacter pylori, and with the Hodgkin. Immunotyping, this is the most important to mention in your investigation as a specific. Immunophenotyping, you will impress the examiner whenever you mention this to the examiner. Immunophenotyping or flow cytometry. CD15, CD30. It's not important to know what, but at least to mention it, because this is one of the diagnostic criteria for lymphoma. The last thing, the treatment, chemotherapy. As I mentioned, chemotherapy plus or minus radiotherapy. And this is for Hodgkin lymphoma. However, in non-Hodgkin lymphoma, it depends on the subtype, chemotherapy plus or minus target therapy, rituximab in some patients. Thank you, Dr. Samira, again, for sharing this. It's a very important one and informative. B symptom, Dr. Hosni, is used for diagnosis lymphoma flow cytometry. Yes. No, it's for leukemia. The flow cytometry, I remember for both, Dr. Omar. Flow cytometry, it can specify the type of either lymphoma.
For both.
Yeah, and leukemia, yes.
type of cells and which group.
But for the lymphoma, the problem
Yes,
might
it
not be
involve
the,
lymph, but also there are some percent in the blood, and we can determine according to flow cytometry which T or B lymphocytes and which cluster of differentiation of CD15 or 30 or 33 and so on.
So
yeah,
in
but
both,
yes, it's usually yeah. As far as I remember from the hematology rotation, to be honest, they tend to put it for the lymphoma patient, but usually this level of discussion will not be in
yeah,
basis.
yeah, it's beyond the basis, right? But at least to mention it as a specific investigation.
Yeah.
Okay, yeah. I remember I had a case of lymphoma as long clinical consultation, and I mentioned all this investigation, and I got full mark. The immunophenotyping, the ultrasound abdomen, CT cap, chest abdominal pelvis as imaging, and the specific I mentioned, and the general investigation. But the invasive one, I remember also I mentioned to him lymph node biopsy. He asked me what else. Although he gave me the full mark, I couldn't give him the answer of what else after the lymph node. I said lymph node biopsy. So what more after the lymph node biopsy? Then outside, I recall when I search bone marrow biopsy also can be helpful to diagnose the lymphoma or lymphoproliferative. So either lymph node or bone marrow biopsy. You can do both. Okay.
One quick recap, Dr. Bassem, about the hepatosplenomegaly differentiation or
Mhm.
differential diagnosis. Whenever, if we have an isolated splenomegaly,
Yes.
you need to, when you say it, it's better to be said as it's a splenomegaly with no other organomegaly and with no other lymphadenopathy noted. Or is it with other lymphadenopathy? And then to list your findings, this is your spot diagnosis. You have a splenomegaly, isolated splenomegaly, or is it splenomegaly with, or it's hepatosplenomegaly, or splenomegaly with other lymph nodes involved, with or without anemia. And then you enlist the finding from inspection, palpation, percussion, auscultation. But the differential diagnosis for the splenomegaly in general would be due to the infection infiltration and storage diseases, as we mentioned, or is due to functional increased function of the spleen because of hematological problem. Likely, it could be the membrane, the red cell membrane problem, as in hereditary spherocytosis, or the hemoglobinopathies, either sickle cell or early stages, and thalassemia to prioritize it above that, or due to portal hypertension due to cirrhotic liver. You couldn't appreciate the liver because it's cirrhotic, it's shrunken, and you can list the causes. I hope this helps if someone didn't have a differential diagnosis already made in his mind, like, or mapped it in his mind.
Yes. Thank you, Dr. Amar. Again, it will be guided by the examiner. If you have both hepatosplenomegaly, he will ask you what differential of hepatosplenomegaly. If only spleen or splenomegaly and it's huge spleen, he will ask you what the differential of huge splenomegaly. If there is association or the cause related to portal hypertension because of shrunken liver or cirrhotic liver, he will ask you what is the possible differential of cirrhotic liver associated with splenomegaly. And everyone will give you different differential diagnosis, as Dr. Amar mentioned. So, okay, so put it in your note. The abdomen station doesn't have a lot of cases, either autosomal dominant or adult polycystic kidney disease, or scars, or hepatosplenomegaly, or isolated splenomegaly, or splenomegaly because of portal hypertension. So be ready to have these finding or these cases and the possible cause and the possible differential for each category. So it's easy. You can write it in your note and be ready to have one of them in your exam. Okay, the other feedback, sorry, other comments in the chat box. Yeah, the finding was splenomegaly. Okay, and what the signs of chronic liver? Why signs of chronic liver dosage disease supposed to mention is always involved in the abdomen station? Yes, Dr. Omar already answered because it's abdomen station. So you have to mention it if there, and if not there, at the end of your presentation, you can say that I couldn't appreciate finding of chronic liver disease. I couldn't appreciate finding of, for example, volume overload. I couldn't appreciate signs of immunosuppressant or heart failure. Okay, this is the complete sentence of your presentation whenever you have a case. If they give you the time to say, sometimes they just pick from you hear from you the finding, then they will proceed with the next question because they are restricted in this scenario or in the short station that they have 4 minutes only for discussion. So no time to present more than what you have. So the positive finding, be sure that you mention the peripheral signs and the central sign. This is my favorite approach or scheme to mention the positive finding in any short station. The peripheral signs, I mean in the hand, either pallor, anemia, either pallor or leukonychia, cholionychia. There is fistula, there is a scar, injection mark. If you finish the peripheral signs, I mean the hands, now you can go to the central signs, I mean the skeleton, the central abdomen or face or chest. Whatever you have to mention. In this way, you will not forget the peripheral and you will not forget the central. If you start to mention the hepatomegaly and the splenomegaly, you will forget, for example, the hand pallor or the hand leukonychia or cholionychia or injection mark or fistula. That's why I prefer always to start with the peripheral signs. Whatever you picked up during the examination in in the hands, present it first, then go to the central part, which is the finding in the abdomen or face. Okay, in this way, you will not forget any of them. And thank you, Dr. Sen. Now the time for Dr. Ahmed performance. So Dr. Sen, he sent me the case. Give me a second just to share it. Dr. Ahmed, you're ready to examine? Again, it's also abdominal examination. Give me a second.
Okay.
Yes, okay. So you have 55 years old patient. Examine his abdomen. Okay, again, we can say this is Mr. Adam. Mr. Adam,
Okay.
55 years. Examine his abdomen. I will start the time. Then you can start the examination straight away. Here you go.
Hello, Mr. Adam. I'm Dr. Mansour, one of exam candidate. I'm asked to examine you. Is it all right for you?
Yes, doctor.
If you feel any pain or discomfort, let me know.
Sure, doctor.
I will start with the arm. For the nail, leukonychia, boyonychia, clubbing.
Okay. Anything else you want to look for the nails?
Is there any betting?
No. No. Okay. Leukonychia, cholionychia is not present. Okay, you can continue.
Can you stretch your arm?
Huh? Stretch. Yes. No tremor.
No tremor. Okay, thank you. I will see the palm of the hand, if any palmar erythema, to between contracture.
No pulmonary erythema, no device contraction.
It's no, okay. I will see the arm, if any needle marks, fistula.
Yeah, I share the photo. You can
Yes,
see.
you can. Did you share? Okay.
Yes, thank you. I will palpate for the fistula, if any palpable
Yes.
well functioning, and auscultate also. I see here
Yes.
needle marks.
Hmm.
Thank you. I will go for the face. Start with jugular veins. Any congested neck veins?
No congestive neck veins.
Okay. Do you have any tummy pain?
No, I don't have any tummy pain, doctor.
I will press you on your tummy and see if increasing jugular veins.
No, it is
Okay,
hyperjugular reflex is absent.
thank you. I will go for the eye, any pallor or jaundice.
No, you might appreciate my pallor, slight pallor.
Slide bar. Okay, thank you. I will go for the mouth. If any gingival hyperplasia, fungal infection, bad hygiene.
No.
Okay, thank you. Any special character in face like lupus malar rash or something like that?
No.
Okay, I go for the chest. See if any gynecomastia or spider nevi.
No.
Okay, I will see if any scar of Portcas or central lines.
Why do you want to see, doctor?
For Portcas or Demar's
Okay.
permanent catheter for dialysis.
If you will see some scar mark of previous HT catheter in the neck.
In the neck. Okay, thank you.
Hmm.
But nothing palpable. No tubal.
No.
Okay, thank you.
No.
So can you sit down, please? I will examine the back, see if any
Mm,
spider nearby, and I want to
no.
palpate the chest to assess volume status, if any crepitation.
No.
Okay, while he's sitting, does you have any back pain?
No.
I will press in your back in sacral edema.
No sacral edema.
Okay, I will examine the lymph node, cervical nodes while sitting. Submandibular, submental, cervical, pre-auricular, post-auricular.
Not palpable.
Okay, can you lie flat, please?
Yes. Thank you.
I will go parallel to the level of the abdomen to see if any ascites, any abdominal distension, or bubble
No.
in a scar, any dilated veins.
No.
Okay. I will make superficial palpation. If you feel any pain, let me know. And I am looking for the patient face, any tenderness.
That's great.
Okay. I will go for deep palpation, first for the liver, while inspiration, while taking deep breaths, any palpable liver.
Liver is not palpable.
Okay. Thank you. I will go for the spleen in splenomegaly, palpable.
Spleen is not palpable.
Okay. I will do renal bruit, renal development. Is any palpable case?
Yeah, you find palatable mass in bilateral flanks,
Thank you.
1 minute left.
both sides.
Okay. I will auscultate the abdomen for any bruit.
No bruit.
I will go for the legs, see if any pedal edema.
No pedal edema.
Okay. Thank you. You can press.
Thank you, doctor.
You're done. You want to do examination for anything else? You have still 20 seconds.
Nothing else.
Okay. Examiner questions, please, Dr. Sen.
Can you please tell your positive physical findings, doctor?
Yes, this gentleman, 55 years old, on examination of his hands, there is a fistula well functioning with palpable cerebral and skull tattoo also. There is needle mark, active dialysis, inactive dialysis. On examination of his face, there is pallor on the eyes, and there is markers of central lines on his necks. On abdominal examination was only palpable kidney both sides and no volume status euphyllemic.
Did you check for the free fluid in the abdomen, shifting dullness, doctor?
I'm sorry, I missed.
No. Did you check the nails for half and half nails, doctor?
I should see it.
Yeah, I just said. So I've asked very specifically. That is why, apart from koilonychia or leukonychia, do you want to? Yes, I agree. So if it is there, then you would pick it up. So no, nothing is there. So your examinations are good, very good. So what is your diagnosis or differential diagnosis?
A patient with chronic renal failure on hemodialysis, an active
Mm-hmm.
hemodialysis. The cause of chronic renal failure in this case was regarding palatable kidney both sides, maybe autosomal dominant polycystic kidney disease as
Mm-hmm.
diagnosis, maybe uh, infiltrative disease like amyloidosis, maybe diabetes, but I didn't see any sensor or blood glucose monitoring in the surrounding. Maybe
Okay.
glomerulonephritis.
What might be the differential diagnosis for bilateral cystic
Autosomal
kidney?
dominant, autosomal dominant polycystic kidney disease. That's the first differential diagnosis.
Yes, yes. Any other differential diagnosis?
That's all
Okay,
cause
so
maybe hydronephrosis, obstructive uropathy, hydronephrosis
great,
both sides.
great, both sides. Anything else? Okay, so how will you investigate him?
I will do for this complete blood count, inflammatory marker, kidney function test, and electrolytes, liver function test. Also, phosphorus, calcium, parathyroid hormone as routine for workup, and do if also the causes of autoimmune markers, rheumatoid factor, ANA, ANCA, hepatitis serology, and also do abdominal ultrasound.
Great. Anything else? Okay, so and how will you manage him, doctor?
So here the patient non-pharmacological, pharmacological, non-pharmacological, pharmacological patient education and counseling about his disease. If the case
Mm-hmm.
of autosomal dominant polycystic kidney disease, I will do screening for the families above the age of ultrasound. If he has any symptom or family history of stroke, I will do CT angio to screen for cerebral aneurysm
Great.
and pharmacological dialysis. And if considering this relative young age, maybe consider for renal transplantation.
Before renal transplant, do you want to give any medicines?
In this stage, when he is in hemodialysis, there is only medication which license for to prevent progression of autosomal polycystic kidney disease, but in this
Mm-hmm.
too late and no benefit from giving tolvaptan in this case.
Yeah, so here he has already been progressed to CKD, so it might not work. Anything else? Any other medicines?
He has control of his blood pressure.
Great. So we need to give some blood pressure antihypertensives. Which antihypertensive is the choice in polycystic kidney disease?
Sorry, I didn't hear clearly.
Which antihypertensive is the choice in polycystic kidney disease?
Which? Sorry.
Antihypertensive.
Which antihypertensive, if
Yes.
on dialysis, ACE inhibitor,
Yes. Great.
in small doses, and the direct vasodilator,
Yes. Great.
reduce
Great.
adrenaline.
That's great.
Yeah,
I
perfect,
think
Dr.
I'm
Ahmed.
very clear.
Yes.
Yes.
I want to ask him how many palpable kidney you palpate or you felt?
In my life,
No, in this patient, how many kidneys
kidneys,
palatable?
2 kidneys.
Two? Okay.
Mhm.
If you have one only palpable or palatable, what you could do?
I will do her urological investigation, CT for the abdomen to exclude any
No, not as investigation. In the examination steps, you palpate the kidneys and you palpate one only, or you felt one.
I search for scar of any nephrectomy.
Okay, perfect. Yeah, how to do it?
I will ask the patient to go on the side to see scar on
Okay,
the lumbar region
yeah,
or in the back.
perfect. Don't forget to examine the back. Sometimes the scar will be there. Okay. Well done, Dr. Ahmed. Thank you. Now, Dr.
One more
Sin will
question,
present.
Dr. Bassem. What is the blood pressure target in this patient?
It is according to society less than 130 when possible.
Perfect. It's one of the tightest blood targets ever in medicine.
Yeah.
Perfect.
Yes. Yes. Yes.
Okay, thank you, Dr. Omar. Now, the comment from Dr. Sun, please. You can start. Again, based on
Uh,
this case. Okay, continue.
yes. So he did great probably. So his scheme of examination is fine. Um, please do not forget to use the hand wash or hand rub before examining. So sometimes that carries mark in the welfare section. So we try to remind ourselves every time before touching the patients to use the hand rub or the alcohol
Yeah, hand
hand wash.
sanitization. Perfect.
Yes. So that is number one.
Actually, I didn't hear that examiners down mark in the welfare because of the hand rub. I don't know. Anyone face it in the
Myself,
real?
Uh,
Dr.
so I
Bassem, in my exam, in my previous exam, when I left the exam, I remember that I didn't wash my, sterilize my hand, but it wasn't reflected on, and no one really uh, like pay attention to this.
But
If you
they
remember,
didn't. No. I am saying no one minus or
yeah, no
deduct
one
a mark.
in the patient welfare, no,
Yeah,
I
they can
checked all
remind you
marks.
to do, but they are not doing the deduction. This is what I am saying.
okay.
I don't know if in real exam anyone has it or
Mhm.
had it. So yeah, they can remind you, but I didn't hear about marks down because of that. Anyway, you have to remember
Yes.
also, it's not an
Yes.
excuse. No excuse. I'm just saying to be careful. Maybe you have a toxic examiner, they might minus you. Okay. Yeah, continue comment, Dr. Sen.
Yes. Rest of the things are fine. Only thing, the shifting dullness was missed in the physical examination sequence. So that is the only thing that I could. He might have forgotten to complete the sequence of shifting dullness. Uh, Although there is no evidence of volume overload, so he was euvolemic. In the presentations, somebody with a CKD, he mentioned that the what might be the cause of CKD. So here it is the bilateral polycystic kidney disease. The current mode of hemodialysis, which is the left-sided AV fistula that he has mentioned, which is uh, which is currently in is used. He checked for the thrill, he checked for the bruit, which is fantastic. I feel we should also look for the any previous mode of hemodialysis, which he also very rightly checked in the neck for any scar, and he found it. So there are certain things we should look for it because the scars might be very faint, so we need to actually search for it. And he also looked for any sign of volume overload. So he auscultated the chest, looked for JVP, and looked for pedal edema, which is again fantastic. I do not remember whether doctor has done checked for the flapping tremor, which might be a sign of uremia and which might be important in somebody with a chronic kidney disease. so that I am not able to remember.
Uh,
Did you check it,
yes, yes.
doctor, for flapping
To
tremor?
stretch the hand and raise
Okay, great,
at the
great. Then that makes it the uh, he doesn't have any uremia. In the presentations, we should have maybe he should have described the kidney a little bit. We have got the bilateral palatable kidney, which is bimanually palpable. We could reach the upper level of the mass, uh, and it is a firm mass by both sides, and the percussion note over the mass is resonant, and there is no associated bruit over the mass. So that makes the examination complete over the kidney. Any mass in the abdomen, it is better to do the percussion, do the auscultations, and also try and characterize describe the mass, whether it is what about the surface, whether it is nodularity is there, whether it is hard, whether it is firm. So those things is would have made it better. Rest everything whatever doctor has done is perfect. I appreciate that.
So you want minus only in the physical examination because couldn't palpate over the mass?
Yeah, no, no, no.
Discuss?
So in physical examination sections, the shifting dullness was not done. So one
Yeah.
sequence was missed. That is the only thing was there.
Okay, some examiners they can put as borderline and others can overlook it and he can give
Yes.
the full mark. Anyway, we are
Mm,
usually putting low threshold in the
mm,
session because you don't have what type of examiner you face in the exam in
mm.
order to motivate others. So be sure that you are not forgetting those steps. Either
Yes.
for the ascites, you don't forget Dr. Ahmed. You did very systematic examination. You did it in perfect and confidence way. You prepare and you inform the patient and you warn him if he has any pain regarding the welfare. The all steps I think you have done perfect apart from the shifting nuns for ascites. The presentation, as Dr. Sen mentioned, of course, if you have time, as I said, the short station, usually they are not waiting more than 1 minute to present your case. So please try to be to the point, what you have picked up, and at the end, you have to mention the four things I usually say in every session. In the kidney or renal failure patient, the current mode of renal replacement therapy, the previous mode of renal replacement therapy, the volume state, and the signs of heart failure. Add to this, if you have a scar or a transplanted kidney, you have to mention the complication of immunosuppressant. Okay, so whenever you have a kidney or renal patient with a mass, try to remember this finding at the end. So you can say, I can say, or I couldn't appreciate, or I could appreciate the current mode of renal replacement, the previous mode, the signs of volume overload or heart failure, and finally you can say about the signs of immunosuppressant or toxic or the side effects. And if you can also have a look to the previous cause or original cause of his kidney failure. So in this patient, for example, you can say adult polycystic kidney disease. Apart from that, regarding your differential, you mentioned, I think the order is not as common as we have. So whenever you start to say the differential or the commonest cause of kidney failure, our patient will be adult polycystic kidney disease. He will tell you what else could be the common. You mentioned, I think, obstructive uropathy as
the
second.
because palpable renal. I search in the second position.
Okay. Oh, okay. If you don't have palpable kidney, so what could be? Yeah, you mentioned amyloidosis. I remember now. You mentioned amyloidosis. Okay, as a palpable kidney, as you said, okay, it's acceptable. But if he asks as general, what are the possible cause of renal failure
It's
Worldwide, yes.
diabetic nephropathy and
Perfect.
hypertension.
Perfect. So this is the most common. You have to mention diabetic and the hypertensive before mentioning the adult polycystic and before mentioning glomerulonephritis, as well as other cause like amyloidosis or vasculitis, lupus. But good to remember all these things and obstructive uropathy as well. So this is regarding the differential. I think also you covered them well, the clinical judgment as well. But if in this case you mentioned the genetic screening, but how to confirm the disease in our patient? So adult polycystic kidney disease, you have two ways to confirm. I mean investigation. What are they?
Yes, there is a gene mutation in chromosome 16.
Perfect. So genetic screening, or if you have, let's do the equation. Okay, let's play the equation game. You remember them?
Unfortunately, it's 4 chromosome 4 of type 2, chromosome 16 type 1.
No. I'm not talking about the genetic itself, the genes.
That's ultrasound.
Yeah, ultrasound finding. Tell
But
me.
for according to the age.
Perfect. So give me the age, distribution, and the number of the cysts.
Unfortunately, don't remember now. So,
Okay. I made it as a tactic, as you know, the football tactic. 4-4-2. So it's similar, but it's a different way. So let's start first by saying the age. So when to start the screening?
20.
Perfect. Okay, and how many? After how many you will say this is autosomal or adult polycystic kidney disease? After
Or I'm not sure. For
5
cyst.
or more.
30, from 30 to 59, and or less than 30, from 30 to 59, and more than 60, right?
Can you explain again? If less than 30 and between 30 and 60.
And 59, yes, and more than 60.
Okay.
And the number, or as I said, the number of the cysts, it's 244, right? 244.
Okay.
Okay. Now to say how many, sorry, 224. Sorry, yes, I meant, yeah. 224, not 244, 224. Okay, I want to be sure that's from 15 to 29. Two or more cysts, unilateral or bilateral. So you have two, either in both or one of them. Two cysts, you can say this is adult polycystic kidney disease. Okay, from 30 to 59. Two or more in each kidney. So you have to have in both kidneys. Two. So the first one will be two, either one unilateral or bilateral. The second group from 30 to 59, either you have to have two or more cysts in each kidney to diagnose it as adult polycystic kidney disease. So again, 224. The last age group, more than 50, more than 60, you will have four or more cysts in each kidney. To say this is, so you have in both sides. Let's repeat them again. Recall. From 15 to 29. If you have two or more cysts, either here or there, right or left, you can say this is adult polycystic kidney disease. Two, the second group from 30 to 59, another two, either in both kidneys or one of them, two or more cysts in each kidney. Okay. The third group distribution, more than 60, four or more in each kidney. So whenever you are going, the number will be more to diagnose the adult polycystic kidney disease. Okay? Because sometimes you have accidental cyst in the kidney, or accidental finding of a cyst or two cysts in a kidney. But how you can diagnose according to the number, as I mentioned, 224. Okay, if you don't have and you have family history, and you do screening by ultrasound, and you didn't find the number, and this patient is, for example, going to donate his kidney to his father, what you should do?
Genetic analysis in this case.
Perfect. Yes, so we have to do and to confirm diagnosis by genetic. Why? Because this patient is going to donate his kidney. Either it will be unhealthy kidney, or himself he will have kidney failure in his elderly age. This is regarding the screening, the investigation, the management. Already you talk about the pharmacological option, tolvaptan, vasopressin 2 receptor antagonist, control the hypertension. You can add also the low salt diet, controlling the hypertension itself by lifestyle modification. Okay, just show the examiner that you are taking care of this part. Usually, our mistake, all of us as a candidate, whenever the patient, the doctor, sorry, examiner asks how to manage, we remember the pharmacological. And the smart doctor, I can say also he's clever. If he start to speak about the non-pharmacological in the form of counseling, education, and the lifestyle modification, genetic counseling, as you did exactly, it's a really good impression to the examiner that this patient, this doctor know how to manage without talking only about the pharmacological. Why? Because sometimes you don't remember the name of the medication, for example, and you will feel like, oh, I'm stuck. I forget the name of the pharmacological, and the examiner doesn't need to hear the pharmacological option only. He needs to hear the counseling, the education, the complication, avoid the sports or contact sports if he has polycystic. Avoid also the lifestyle, erratic lifestyle. Control the blood pressure, control the diabetes, for example, if he has diabetic nephropathy. And the genetic counseling, genetic screening for the family if he has adult polycystic kidney disease. And multidisciplinary team, whenever you have confirmed the diagnosis, multidisciplinary to control all these factors. Okay, be smart again. Don't start by pharmacological. Okay, I'm done with my comments. So good and well done, Dr. Ahmed. Any question, Dr. Ahmed and Dr. Sen?
No, that is great. That is fantastic.
Oh,
I would give him full marks probably in the station.
yeah, yeah, I deserve this. Any
One
question?
more question
Yeah.
to both doctors is about if this patient has presented to you in ED with abdominal pain, what's your chain of thinking in this situation? The same patient that
Okay, maybe
the last
complicated cyst like bleeding inside the cyst or infection.
Mhm. And how you are going to manage him?
I will do first painkiller to stop the pain and do urine tests to check for infection and inflammatory markers, and the ultrasound can determine the nature of the cyst of any hemorrhage inside it. If painkiller didn't help him, I proceed for surgery.
Oh, great. This is what's actually wanted to hear. The examiner wanted to hear. It's a urology referral. If this case came as a renal transplant, the question might be, do you usually, do you think it's this kidney in autosomal dominant polycystic kidney disease should be removed for transplantation or not?
That's
The answer, no. The default, no. We will keep it unless if you want to make a room. Or after the transplant, he even had chronic pains because of the hemorrhage or frank hematuria. This would be will be the causes for nephrectomy in such case. So these two types of question, if it comes as this case today, or if it comes as a renal transplant case.
Yeah, perfect, Dr. Ahmed. Don't forget to add intractable pain. So either you have pain or hematuria or recurrent infection, and to make a room for new kidney. These are the indication to do nephrectomy. Again, recall again. indication for nephrectomy in adult polycystic kidney disease. The first one, in the top of them, to make a room for the new kidney. The second, intractable pain or recurrent hematuria or recurrent infection. So these are the indication to remove the kidney in case of adult polycystic kidney disease. Any other question before reading the comments? Dr. Samira wrote, the causes of isolated bulbable kidney hydronephrosis, most common, renal cell carcinoma, Wilms tumor, renal cyst, pyelonephrosis, renal abscess, unilateral polycystic kidney, unilateral nephrectomy, compensatory hypertrophy. So these are the causes. But an exam or basis wise, on the top of them, you have to say the adult polycystic kidney disease. It's very, it's to the point. They want to hear it. Yeah, hydronephrosis can be, the amyloidosis can be, but they want to hear about the adult polycystic kidney disease as the first and the most common to present in PACES. Dr. Omar, when he found palpable mass in the lumbar area, he should check for size, percussion, for resonant, or not tenderness. Check the upper border to check for the cannot go above or it or not. Move a respiration or not. Yes, you have to mention all this while describe this mass. Otherwise, he did. Yes, he did perfect. I think both of them. Again, Dr. Samira wrote it. Less than 30, one cyst or two cysts in one kidney. 30 to 59, two cysts in each kidney or more. 60 and above, four cysts in each kidney. Again, it's 2, 2, 4. Remember this and try to just describe according to the this number. So 2 to 4, 2 in less than 30 in both kidney, and or one kidney. Again, 30 to 59, two cysts in each kidney. So you might have four cysts, and the last one more than 64 cysts in each kidney. So you might have 8 in both kidneys. Okay.
Yeah,
Any oth- yeah.
sorry. One more thing is to summarize the comment on any renal case. In
Mhm.
any renal case, as you should state that it is a patient in end-stage renal failure on hemodialysis or a renal transplant. The current mode of renal replacement, the previous mode of renal replacement in form of old line scars, and the peritoneal dialysis, but it's not common outside UK, and the patient volume status, and the cause behind it. So this is, you have a complete comment before the next question. This shouldn't be taking 30 seconds. So if you state it like this, they will not ask any further question. I from just examining the patient, it's not clear for me that the reason behind, or oh no, this is an autosomal dominant polycystic kidney disease is likely. If you found an frequent blood sugar marking or an insulin injection scars like the lipoma sometimes, that from the frequent insulin injection, oh, I think this gentleman has diabetes from the evidence of needling around his tummy or in the blood sugar monitoring. So this could be the possible reason in this gentleman. Hope it's clear.
Yeah, perfect. You can add also the CGM in the arm. Whenever you are examining the arm, go further. In the arm, you might have also the CGM, Libra machine. So it can give you also the complete picture of the underlying pathology, which is diabetic nephropathy. Any other question or comment? Dr. Sen or Dr. Ahmed or anyone?
No, thank you for organizing these sessions. Thanks a lot.
You're most welcome, Dr. Sen.
Thank you, Dr. Bassett and
Most
Robert.
welcome, Doctor. Most welcome. Okay. So yeah, we can end the session now. Thank you, Dr. Ahmed, Dr. Sen, Dr. Omar, and everyone attending today. See you tomorrow inshallah with the non-clinical consultation day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Good night.